So we'll get started today. My name is Kate Walker, and I work with the Auto Model for Smoking Cessation. It's my great pleasure to introduce Dr. Richard Hurt and Dr. Andrew Pipe, who are going to have a great conversation with us today. Dr. Richard Hurt is a professor of medicine at the College of Medicine, and he's the director of Nicotine Dependence Center at the Mayo Clinic. He was a first witness for the state in the historic Minnesota tobacco trial, the case that transformed global tobacco control. And Dr. Pipe has asked, as he's very humble, that I don't give him a long introduction, but he is the chief of the Division of Prevention and Rehabilitation at the University of Ottawa Heart Institute.
Well, thank you very much, Kate. Do we have an audiovisual guy in the room? Is he dealing with that feedback as we speak? I'm sure they are. So thank you for joining us this morning. This was a session that we pioneered, that we introduced last year, a master class, a conversation with them. And we think it's a particularly appropriate opportunity for you to have a one-on-one kind of conversation with, if you'll forgive the term, a guru. Professor Richard Hurt, or Richard, as I know, is absolutely masterful in terms of his experience and his knowledge and his insight. And I say to many of my younger colleagues, if you want to know anything about tobacco control and clinical approaches to smoking cessation, just go on to PubMed and look at any periodical that Richard Hurt was an author or a co-author of. And if you just put those together and punch some three-ring holes in them and put them in a binder, you'd have a definitive and an enhanced understanding about how to treat smokers. And if the other point that I make is do exactly the same thing using the term Neil Benowitz in your PubMed search engine and assemble all of those articles, you would know everything there is to know about nicotine and everything there is to know about the clinical practice, contemporary best practice for smoking cessation. So it's a particular pleasure, Richard, to have you here today. What we didn't mention at risk of embarrassing you is that, of course, the game of basketball was invented by a from the Ottawa Valley, a little town called Almonte, from which Bob Reed hails. Now, I can tell you that Bob Reed can't shoot a basketball for love nor money, so it's really advantageous to people in places like Kentucky took up the game and brought it to a different level. You told us a little bit about yourself this morning, and I think many of us got the understanding and got to feel familiarity with you as a consequence of that. But one of the things that was curious to me is you were a medical student and a 3-pack-a-day smoker. And at that time, was there any mention in medical school about smoking and the consequences of smoking?
Well, there was virtually none. We had some classes that talked about lung cancer and heart disease. But remember, I graduated from medical school a long time before you did.
Yeah, that's very obvious to, I think, all of us.
So I graduated medical school in 1970, and we had a large number of smokers in our class. In fact, in biochemistry, which was an old medical school, University of Louisville, and there was a flat level for the people, and then there were risers in the back. We had 96 students in the class, and the first row in the risers were all the smokers sat, and we smoked in class. It was amazing. And so, and my cadaver in gross anatomy had COPD. But just to tell you the rationalization and denial that goes through the mind of a person who has a dependence, my rationalization was, this will never happen to me. And so, we were one of the first groups to start talking about tobacco dependence as a dependence. I stopped smoking in 1975 and went back to the smokers clinic. One of the first things we did was begin to talk about denial and rationalization, and it resonated with the patients, and they understood what that was all about. So when we started our clinical program in 1988, and that was the first year this first Surgeon General's report on nicotine addiction was written and published in 1988, and we were talking about this, almost a decade before that. So understanding this is an addictive disorder not only relates to what it was like in medical school, because there were a lot of us who were smokers seeing patients. In fact, I went back to my 40th high school, 40th medical school reunion, went to the gross anatomy lab. This is in Kentucky. And they had on the wall a listing of the diseases that each one of the cadavers had. 30% had lung cancer. It's still a very prevalent problem in that state, and it's changing slowly.
Richard, what do you recall for the first time a clinician or a colleague talking about the need to intervene clinically?
Well, it's actually a story. I had sarcoid when I was a second-year student in college. I was fatigued, a little bit of fever, went to the doctor, they took an x-ray, it showed hyaluronopathy, and this was a little town, Murray, Kentucky, and the intern said, this is a serious problem. I don't know what it is, but it's something that could be Hodgkin's disease, it could be tuberculosis, it could be lung cancer. I was, just a kid, basically, sophomore in college. And so he said, I think we need to refer you to the Mayo Clinic. And so he did, and so my father, my brother, and my two grandmothers went along with us to the airport in Paducah. And I'll never forget getting on the airplane, and they were waving goodbye, and my brother, who was in law school, my father, my two grandmothers were waving goodbye to me. And I said, I may not be coming back. So when I got to Mayo Clinic, they made the diagnosis as sarcoid, and so it's something that was not going to require any treatment. Sarcoid is an inflammatory granulomatous sort of condition that usually is self-limited. And so when I got the report from Dr. Randall, I'll never forget this, and I said, he told me what it was and what this is all about, and I said, does my smoking have anything to do with this? He said, no, gosh no, it doesn't have to do with it at all. I said, whew. Then I'm going to have to stop smoking. I didn't say that out loud, that's what I thought. So if it wasn't caused by smoking, then I didn't need to stop smoking because he didn't tell me to do that. And actually no one ever really told me that I can recall very directly. And I saw physicians a lot. I saw a physician in Louisville, and so I don't recall anyone ever saying you need to stop smoking. And certainly no one said, this is how we can help you with it, but this is a long time ago.
Yeah, so now you're a sophomore, and tell me a little bit about the kind of, what made you go to medical school? I mean, apart from the fact that you were clearly not going to make the MBA. I saw your vertical in that slide, and I can sympathize.
Well, I always wanted to do something that interfaced with people and help people. So if I had not gotten accepted to medical school, I would have gone into teaching. And that was kind of my second choice. And I wasn't a real great student. If I were to apply to medical school today with my grades, I'd never get in.
Hands up, physicians in the room that share that.
I would not get in. And because all I had to do back in that day and time, I graduated from college in 1966, so all I had to do was compete with the good white men, or males. That's all I had to do, because in our class there were 6 women out of 96, and there's not a minority represented in the entire class. So I was very fortunate to go to medical school at that time because of the competition wasn't nearly what it is today. Our son Ryan went to the University of Louisville Medical School, and his class was the first one that was predominantly women, and a lot of African Americans as well. So when I was growing up, the expectation was, and there was a spoken expectation. My parents made it known that we were expected to go as far as we could in school, and that they would finance that all the way to whatever level we wanted to go. My father was the first college graduate in his family. My mother graduated from high school, but not college. And so both my brother and I went on to professional school. He became a lawyer, and I became a physician. And so once I got to the point in college that chemistry and biology were my major, then I got interested in medicine. Had I not gone into medical school, I would have stayed on and gotten my teaching certificate.
So you're in medical school now, and you're thinking, as all medical students do, about a career choice. You decided to go into internal medicine. Was that something that was obvious?
No, well, I liked everything. So after graduating from medical school, went to internship, and during my internship was a rotating internship, but I decided I liked internal medicine better. And so I changed to a straight medicine internship. Then I got drafted, so I spent 2 years in the Army doing general medicine at an Army depot in eastern Kentucky, on which we had nerve agents stored, GB and BX, which are the most potent nerve agents on the planet. So I know what weapons of mass destruction look like because they were stored in rockets that were on our depot. But I did a lot of general medicine there. Then during my internship, there was a group there that encouraged me to go to Mayo Clinic to do training. So I went after Army, I went to Mayo to do internal medicine training. I liked every rotation. So if you like every rotation, it's hard to decide on one. So I decided that I'd go into general medicine.
And I guess as a military physician, you were also in an environment in which there was widespread availability of cheap tobacco products, and this didn't figure prominently in the discussions of the day.
Not at all, and so cigarettes back then cost $0.25 a pack. So, I mean, they were in the PX they were dirt cheap, and so being a smoker, that was hog heaven.
And so you finish your Army career or your Army service, and you then go to the Mayo Clinic. And you kind of alluded to this morning. I mean, when did the penny sort of drop about the tobacco?
Well, I stopped smoking dozens of times, and so there was an epiphany when my wife said, "Let's go to the smokers' clinic." She had signed us up, so 3 of us went, and both my wife and I stopped smoking. She relapsed later, and now it's about 18 years absent from smoking. And I think it's kind of funny. They had a group of people who had been to the smokers' clinic before, a panel of ex-smokers. And we do this in our treatment program now, in our residential program, because it's patients like to tell their stories. And other patients like to hear other patients' stories. So when we created the Center for Tobacco-Free Living, which I didn't show a picture of, we have patient stories as a very prominent part of the display. We don't have lung cancer and heart disease and emphysema. There's hope, there's help, the neurobiology of tobacco dependence, and patient stories. And patients like to tell their stories. So we had this panel of ex-smokers, and I asked the question, and my wife was there, I asked the panel, now, we're here together, and we're trying to stop smoking together. So if I stop smoking and she doesn't, what am I going to do about that? And the guy just really hit me right in the head. He said, "That's your problem. Just because she doesn't stop smoking doesn't mean you can't stop smoking. What you're doing is you're setting yourself up to be able to smoke again. Don't use your wife as an excuse." And he just hit me right over the head with it. I'll never forget that. And it was kind of one of those epiphany moments and he was right. I mean, I was rationalizing and denying, and all these things were going through my mind that, well, how am I going to weasel out of this and continue to smoke? And I'm blaming it on her. That was the easiest thing.
So I take it that attempt was successful, or
Yep.
thereafter?
That was November 22nd, 1970.
And where were you in your residency at that point, or were you on staff?
I was in my last year of residency.
And you subsequently came on staff.
Yep.
And you were doing the general internal medicine practice. And something must have happened in the course of...
Well, I went back as a counselor to the smokers' clinic on a regular basis because I had experience with addictions during my training, so I went back as a counselor for the group program. So the smokers' clinic ran once every quarter or so. It's 8 weeks long. It's kind of a traditional behavior change treatment at that time. We had 8 sessions, 2 hours each session, an hour of learning and an hour of group. So I went back as a group leader. And then when the founder of the smokers' clinic decided to step down, he asked me to be the medical director. And then in the mid-'80s, after doing that for several years and becoming known as someone that had some interest in this, I got 2 telephone calls in the same half day with people with vascular ulcers. One was on dermatology, one was on vascular medicine, and the question was, we have these smokers, we can't help them, we can't get them to stop smoking, and at that time we still allowed smoking in the hospital, and the question was, what do we have to offer these patients? And the answer is nothing. Because all we had at that time was the smokers' clinic, which only ran once a quarter. So we got a group of people together to decide how we could best help the institution to address this problem. And that's where we adopted the pillars of our program: behavior treatment, addictions treatment, pharmacotherapy, and relapse prevention, and most lately wrapping that into motivational interviewing around it. And that's how it all started.